Welcome, friends and colleagues here that you can see, those that you can't see, all around the country and perhaps the world. I want to join you today. I want to just thank everybody for coming and participating in this conversation with a group of trailblazers, people who really care about emerging models for serious illness, and not only care because they've done it, but care so much that they have thrown their whole beings into creating new innovative things to do for these populations that need us so much. I want to take a minute too to thank HAAHPM for organizing this. Honestly, as entrepreneurs, we don't often get together unless someone helps organize us. So HAAHPM, thank you for allowing us to have this venue to share what we're doing and also learn for participants about how they're thinking about things and the questions that they have. So we want to jump right into the content because we've got some fabulous people here and things to talk about. And I do have a poll question that we're going to get into later in the session today. But first, I'd like to just say hello and a little bit about me as your moderator, and then jump into intros for my colleagues here on the call. So I'm Katy Lanz. I've been in this serious illness industry for over 20 years, the first decade at the bedside, and like my colleagues here, watching every day the fragmented health systems around us fail our communities and as a whole. Mostly the frailest, oldest, and sickest, but often it's populations that we don't think about too, that are suffering and living with chronic disease that really need our support. I have spent the last 12 years really focusing on clinical model design and value-based integration, and how we take the traditional medical sense of how we provide care in a fee-for-service world and think creatively about what people really need and what we're able to do for them at the bedside and where they want to be, and really about what matters most to them. And so that has been through a series of different roles. I currently serve as the Chief Strategy and Product Officer for Personal Care Medical Associates, which is a growing geriatric and palliative practice who meets patients where they live in the community. And so I want to thank you for joining me, BJ, Chelsea, and Michael. And so why don't we just start out, each of you giving us a little bit of information about who you are, and I have a litany of questions and curiosities, both for myself and others who have posed some questions for you guys. So let's start out with you, BJ. Tell us a little bit about you and your history.
Thank you, Katy. And yeah, thank you, HAAHPM. Eagle, thank you for putting us together. Like you say, it's rare that we actually get in the same room. So it's nice to be here. So my arc, I'm a physician, an educator, I suppose is the best way to put it. I've been practicing palliative care like you, Katy, probably about going on 20 years or so-ish. You know. And my arc has been sort of started academic, regional kind of medical center, inpatient, outpatient kind of stuff, moved out into the community. And then I just kind of kept moving this way. So kind of heading out more and more, in some ways now, to a sort of a non-medical way of thinking about a lot of these issues. So for the last 2 years, the full thrust of my work has been with my partner, Sonia Dolan, and we created this little telehealth palliative care service called Mettle Health, METTLE, Mettle Health. So it's, it was an effort in the wake of the pandemic to make palliative care more accessible and to follow in footsteps like Michael's with resolution care and really embracing the technology piece. But our particular model, we've let go of the medical piece. So I am a physician, but I'm not practicing medicine through Mettle Health per se. Our model is to complement existing structures and services. So we are all clinicians counseling people how to use their clinicians better and how to navigate the healthcare system, and also how to leave the healthcare system behind when appropriate. So that's the gist.
Wonderful, thank you, BJ. And I have to say, as a colleague of BJ's, if you haven't seen his TED Talk, you should. We've used it, many of us on this call, to help educate and think about how both we live and think about dying in America and beyond. And so highly recommend it. And he has lots of other work out there. I would recommend, both as a clinician and someone who teaches others how to do this important work, and really generally the public about what options they might have. Thank you. Chelsea, we welcome you, Dr. Garcia.
Hi, everyone. First of all, thank you for Hospice Corporation. It is an honor to be here. So I have a bit different story. I actually trained internationally in terms of, I went to medical school in Ireland, and then I returned to my home country of Trinidad, knowing I always wanted to do palliative medicine, but realizing, as Katy said, the fragmented care. There is no palliative training or any subspecialty training in Trinidad. So I hopped on over to the US, where I trained initially in internal medicine and then palliative and hospice. And at that time, I always knew I was going to go back to Trinidad and build a community-based program. So I spent a lot of my time through residency as well as fellowship building that. And here I am back in my native land, doing what I set out to do, but faced with challenges that I didn't foresee. So I was trained with what I didn't see at the time was abundance, but things like fentanyl patches and long-acting morphine and methadone. And then I came home and I was faced with who to give the last vial of IV morphine to, and how do I actually access my patients and go beyond where the road can't go any further. I also, the palliative medicine philosophy was so different to practice when you're on your own and you don't have that team. So I built a team of very passionate people, and I feel that we do good work. We're just continuing to try to see how we could do better. And I think that's why we're all here today, because we want better for our patients. So I'm currently the CEO and founder of Live Health, and we are growing exponentially every day and looking for support along the way. One of the things that I recently developed, I would say it was developed by patients themselves, was a book, almost like a workbook. It's called Becoming Me. It's available on Amazon. But what I did is I realized that I wanted to extend my visit, because not only was time constraints and there's only one of me, but there was also all my patients of fee-for-service in a place where very little can afford not only my services, but the services of maybe a counselor. And if I was limited in medications, I really needed to hone my skills of existential distress. And I was getting patients very early in their palliative course. So I had the ability to really make substantial change. So this book is a workbook, and really it is something that I give my patients to do in between visits. I always say, could you do this page and that? Thanks for sharing. And I would love to hear about it on my next visit. And that helps me not only tackle the medicine in a short time, but try to hone in on a little bit of social, spiritual, and psychological. So that's one tool that we've come up with. And I'm sure we're gonna be needing lots of tools and lots of support from all avenues. And that's me. And I think, something like this is great, because sometimes we always feel like, we're this person, or we're that lone person. But we need a team, we need support, and we need to learn from others on what different models we could continue to learn from and what solutions.
Thank you so much. I'm so glad you said that too, about the book that you've created that extends the visit. In palliative care, historically, it's been primarily medicalized work. And it's interesting that both you and BJ are really kind of thinking beyond that, and how we hone in on the things that data already suggest. Recent study that 80% of the possibility of someone to be able to stay at home and both live and die the way that they want to depends on those social needs and all of the things that you're talking about. So thank you for sharing that snippet above and beyond what your practice is doing. All right, Dr. Fratkin, your turn.
Well, thank you, Katy. Thank you, Chelsea. We hadn't met before this, and just getting the download from you about how you arrive at this work and in this room is really had impact. And BJ, my friend, y'all are so brave. And I also kind of moving away from the center of the healthcare system, but I haven't been brave enough to let go of all the credibility tools and leverage that comes with the whole doctor thing and the whole health insurance financing thing and everything else. But thank you for having me. Thank you, Yigal. I am a country doctor. I live up here in far northern California, and I struggled mightily for many years to try and use the systems and structures of healthcare delivery that exist to produce something that was sustainable, that was inspiring to me. And I struggled and frustrated and whined on my friends' shoulders about, why do I have to be a doctor now? Because I was most inspired by William Carlos Williams with his little empty little medicine bag and his little horse-drawn buggies, and people coming with whatever they had, which was mostly nothing in terms of medical tools, to serve people as they were dying. And I just couldn't figure out a way to engineer it in the status quo structures of the healthcare system. So I was either crazy or stupid or some combination of both, and launched Resolution Care, a community-based, complete team-based palliative care intervention with the hook that telemedicine could be a valuable tool. And over these years, we figured out how to get out of our own way, to make the structures of financing and healthcare contracting and ever always improving quality where measurable better. And we are a much more substantial and significant entity to date. We can talk about more of the details in the evolutionary process, but the bottom line is that it's really always been about me trying to shake off the magnetism of burnout, given that I'm a doctor in this particular time and place.
Yeah. And you hit on something that I think is often what stimulates the entrepreneurial mindset and the creativity of, I've got to break free and think about how I'm going to do something else. And I was going to ask a question, and since you just brought that up, Michael, I'll start with you. And that is, what that moment was. I mean, I think, for me, it was as originally an ER nurse, coding people in my community that I knew were dying for a really long time. And being very frustrated with the fact as a nurse that I wasn't allowed to tell them the truth about the future of their care and their life and what choices that they might have. And I heard that frustration in your voice a bit too. You didn't say it in the same way, but I think that's where creativity is spawned. And I think for you, I'm very curious now that you've shared, just kind of what propels you and why, what you want to be like and what you want to envision, and the founding principles, I guess, of Resolution Care, which is to be there with people as they're thinking through these choices that they have and give them that expertise to make those decisions. We're doing it in an environment of extreme barriers at the same time, and payment mechanisms that may or may not support us. So I'm curious to hear from you what you think needs to happen inside the healthcare system, in order to improve the care for the patients that you're treating today and beyond. What are some of the key, and I know there's probably a list of,
oh my God,
yeah, but what are the big ones that you see?
Yeah, no, I mean, the first part of the question you sort of asked, like, what was the sort of generative thing that exploded me into the risk universe of being an entrepreneur, which is just such a funny thing for me to take on. But my chaplain this morning in a meeting sent us out into our day this morning. She said, give it all you got, give it 100%, unless you're donating blood. And then she, the idea being I was depleted endlessly, continuously, and perpetually, giving more than I could actually stand to give inside of a system that wasn't repleting my energy. And I knew that I had to create a closed loop, that I had to design something that was feeding me as much as exploiting my amazing energy for caring and healing and all the rest of it, all that wonderful stuff that I want to do, that we want to do, this whole community of folks. We move towards the things that everybody else is running the other direction. It's just part of our nature as caregivers. It sent Chelsea on a global journey to come home with tools in her tool bag. And it's empowered BJ to keep moving left or right or whichever direction you pointed, I don't know. But that, we have a lot to give, and the people that we love and work with, our colleagues, have a lot to give, but we can't give beyond that which is sustainable. And watching myself suffer, and now going forward in time and creating opportunities for people to have sustainable, nourishing work that brings the best and the most that they have to give, but matches it with supporting them in a coherent and integrated framework and culture that allows them to give as much as they can, but then go home at 5 o'clock and live a life, you know? So it's sort of, that was sort of degenerative frustration back in 2014, and then a lot of really good timing. The second part of your question was, help me, Katy?
To really, you know, when you look at that brokenness,
Yeah.
what is it that you see that really needs to change? And you could address it from a workforce component, or if you'd like, because however you'd like, because that's kind of what you hit on, is that burnout issue, and also, you know, sustainability. But
I won't take a lot of time. I'll just say that the one thing I knew from the minute I started, actually before I started my medical training, was these people in the beds with their oozing and their bleeding and their moaning and their suffering were the same as me. That there is no such thing as a patient. And then what I noticed in my training that I couldn't turn my attention away from was, in addition to their suffering and those that love them, my colleagues were suffering. Now, something that BJ has taught me is kind of principles of design. And I'll quote, you know, that the system that we have produces exactly the results that we have because it is so badly designed. And I'll just drop this into the space for further discussion. But I think that the fundamental element missing, the design element that I would target, is economics and justice. Those are the two things that I think I have targeted in the work that I'm doing. Justice for the people providing the care, as well as making access for those that need it across all kinds of, you know, artificial boundaries between this kind of a person and that color of a person and this geographically located person. The tools of using telemedicine have allowed me to break down some of those barriers. And because I've realized that the people doing the care are also people that we built and engineered an organization that really creates a sustainable and nourishing environment for professional and personal well-being and development.
it's funny that you choose those two tenets, because I think it plays upon the mission and margin of the work too, to some degree. The economics and the unit economics of how things are set up, and they do, yes, feed some behavior, but it's also the justice and the principles of ethics that we know that drive us, and marrying those. That means like doing the right things in your entrepreneurial ventures as well, but tied to a sustainable business model are really important. You can't do really one without the other, you know.
We aren't making ball bearings over here. We are not making ball bearings. We are doing something different.
Yeah, and I think as clinicians, that latter, building the business case is where we really look to a lot of our colleagues and friends, and our things that we've had. For me, I can speak for myself, had to teach myself along the way, and then share, what we learned. So thank you for that. And Chelsea, I'm going to save you for last because, some of the things that have really been those pivotal moments of what you're bringing back are very unique. But so BJ, let's jump to you and kind of think through, this same question. And I know it's not necessarily a pivotal moment, but more of a fundamental lesson or experience that provided focus and passion for what you're doing. And then how you feel like, this is threading through some of those barriers that we are seeing out in the communities and systems today.
Yeah, so I mean, a lot of similar experiences, not surprisingly, with Michael's trajectory, and a lot of the same realizations, and a lot of the same trying to uncover what we know should be true. This sort of the reciprocity of care, that caregiving, care receiving has to flow in all directions. That and good on the subject matter as an actual equalizing force. And so everything, I'm with Michael all the way. For me, sort of other pieces of this puzzle have come from, I started as a patient. That's why I got interested in medicine. And that was a really, without being sadistic and wishing pain on people, it's a really great way to enter healthcare, because you have that, not the bedside view, but in the bed view. If you really know that, then it's a process of going and getting this training and then trying to wed those two experiences. And it's that easy and that hard in some ways. One of the, it wasn't, I had my disillusionment around health and healthcare before entering the system in some ways. And I knew I was going to be heading in as something of in a countercultural way. But, more specifically, tactically what needs to change, you might name some of the simple things to state anyway, would be more time. The 15-minute encounter is insane. It is impossible. So we have to acknowledge we are asking our clinicians who go through so many years of training, all this debt, we teach them how to provide exquisite care, and then we don't allow them to. The structures of healthcare, it's not possible. So we are in an impossible realm, but I've become enamored with limits, because the limits are where we get creative and where we find our workarounds. And that has pulled me outside of healthcare in a lot of ways. But part of the realization about that more strategically is this realization that, wow, healthcare, if it was designed at all, it has been designed around diseases. So for me, it's a conceptual shift. I'm with you, Michael, on economics. There's none of this is going to happen without the economic argument. But for me, earlier still is the conceptual argument that if we as a healthcare system decided that we are focused on the experience of illness, on people living with illness, living through illness, living with disability, et cetera, not the diseases themselves, focusing on the person with the disease, I think that would right a lot of our wrongs. I think that if you just played that out, we'd be in a very, very different place. And part of that is informed by this realization, trying to explain to the world what palliative care is. And a lot of people look at you like, well, didn't you just describe what healthcare is? And in some ways, you got to understand palliative care exists as a subspecialty because of the brokenness of the system. That's a real mind bender, and it's really difficult to get across, because otherwise people are like, well, I thought this is what doctors are supposed to do: treat my suffering, listen to me. Yeah, of course, duh, but it's not duh, because we have a different system than people. It's not intuitive. And so that realization is part, it helps me understand palliative care's importance, and also the idea, the great goal of palliative care someday going away. If we have our way, we won't need this corrective as a subspecialty. That's a nice organizing theme. And the last point I'll make, I'm sorry I'm going on a little bit, is in this mix, is the realization that you look at the definition of palliative care and you come to realize there is nothing inherently medical about, medicine doesn't have a lock on suffering, mortality. So you know, if we swapped out the mission of healthcare for the mission of palliative care, we'd be off to the races in a big way. This focus on people and experience on the subjective plane, but it's also this opportunity, therefore, the fact that palliative care has reached some sort of officialdom means that big mission of suffering, quality of life is that opportunity to upload other ways of thinking, other disciplines into the healthcare model. It perforates the line of the medical model as being the model, the reality, the truth. It's not, it's a model. And so that's very exciting for me. I think we're just beginning to see how we can load in the social sciences, the arts, all these other things that go into quality of life, but have nothing to do with a typical clinical encounter.
Yeah.
So somewhere in all that stuff is my answer.
It's a beautiful answer, and actually hits on several questions that I actually had for you. And I think that one thing that you highlighted there at the end is that as all of us being palliativist, hope that one day that the medical system changes in such a way that it's just a part of what everyone does, that medicine does. And I think because of the hard work of some of the trailblazers here on this call, but also that value proposition that we've finally been able to bring, we're seeing now a lot of that interest shift back towards primary care and some options for them to extend their services out into the community in different models. And so for the people on this call, boy, oh boy, there is immense opportunity. I saw a question just come in about commoditizing people and human capital as caregivers, and like thinking about that. And I think that there is a really important way of thinking about the human product aspect of what this brings. And it doesn't have, we do have, yes, medical people on this call, but we're here saying it doesn't need to be us. In fact, it should be more and different. So there's a lot of creativity at hand around that. So, and speaking of creativity, Chelsea, you know, took what she had learned here into a system that was, you know, probably where we were in America, I would say, even more differently, but back in the 90s and 2000s. And so she is truly trailblazing palliative medicine and care in her community. So take a moment, Chelsea, and just tell us about what propelled you to do this, and more importantly, go out on your own, you know, into an environment where you really have no, you know, additional supports except what you build to make this happen. So we want to hear about that. Please.
Well, I think the reason is everything that I've heard from everyone on this panel, right? The reason is you're tired of a fragmented system and you're frustrated and you want better. And one of the things I learned, I would say, is, you know, BJ talks about the palliative medicine philosophy. And I could say I could sell palliative medicine to anybody, right? However, you want to make sure that if you sell something, you're not a car salesman, and you're going to deliver on that palliative philosophy. So it really comes down to the delivery, and that's the hard part. And whatever system, whatever country that you train in, it's how you're going to deliver. And that's where we've been, you know, feeling the ground and seeing how we could adapt a system, learning from other people's problems that arose. And that's, I didn't set out to make up anything new. I set out to build on what people have previously done. And people here, in terms of palliative medicine, first of all, I have to be so grateful that the people that have come before me and continue to, as I said, pioneer and trailblaze. I mean, we have 3 little inpatient hospices here with a total capacity of 36 for a population of 1.2 million. But those wouldn't be here today if it wasn't for those trailblazers and those pioneers. So families like Mr. and Mrs. Simangal that bought the Cora Palliative Unit and Vitas House and Cancer Society. These are all people that, again, like us, had that frustration and wanted to do better. And that's where I struggled with my delivery and making sure that what I said was actually what I gave. And on that conversation of people at the bedside and empowering the caregivers themselves, I'll say I've had the most success with that. So when I moved home, the first thing I did was I made sure that I was distinguishing palliative medicine from hospice because I wanted people from the very start. So I invested a lot of money in social media advertising and marketing and truly identifying the difference between palliative medicine. And I would say it really has paid off because the majority of my referrals and my census is truly palliative people. And that's where you get the beauty because they get to know you and you get to follow them from the start to finish. And we have no hospitalizations, very few hospitalizations. So we do good work, but the work we're doing is built on all of us. I'd say the other thing with the caregivers is our model is largely built on caregivers. And a lot of our time is spent educating family or just the general caregiver with no experience on how to care for that patient. And I get a lot of benefit from that because it just comes down to love, passion, and care. And with a little bit of education and with a little bit of empathy and making sure that you're there to support them if needed, you're going to get the best results. And it also maximizes your ability to help the most people.
Beautifully said. It really is. And what important work. And I'm watching these comments come in as you guys are talking, and I'm watching that, you know, like I think all of us have said already is that, you know, palliative care comes in many flavors. You ask 10 people, they might tell you 10 different things. And so how do you build something that is scalable, successful, and that people understand? And I would say a few things, you know, and I think that the panel will too, but sometimes it's not about the word, it's describing what you do. And not asking people if they need palliative care, telling them what you do and exactly what your business model is. And that, you know, these are the patients that should be receiving it. And now we have national standards for that through a combination of the Consensus Project and now Medicare identifying a serious illness population and even demonstrating a model off of it. We don't have to say that we've created it. We actually have, you know, everybody kind of wrapped around this. So being specific and not necessarily calling it palliative care, but saying what you do and how it fits within their overall needs, and then saying what it is and who you will be seeing instead of asking them to send you people that you might see. And I think those are two really important tenets for me as an entrepreneur. I used to wait for consults. I used to wait for business to come instead of saying, this is what I do, and these are the people that need it. And these are two options that you can use to pay me for it. And that's just simply said, you know, that historically as consultants in a medically minded business that we didn't learn. We just took the patients they gave us, and most of which were very, very, very sick and dying within days. And we didn't get to give them those comprehensive services. So, you know, to that, and, you know, as an entrepreneur, that was an aha moment for myself. And that is that in order to break away from the access issues, and I need to tell them what the services are and tell them how to get them and how to pay for them. And so that was my moment as an entrepreneur. But I'm very curious, you know, Chelsea, let's start with you since we just finished. You know, when you think about the shift towards that medically minded, you know, amazing training that you've received and how you're translating that, you know, and becoming, and you've said, I want to be an entrepreneur. I want to own my own kind of business and success in my own environment. What was it that helped you make that shift, and how are you describing those services that you provide, and what's winning for you out there?
Well, I would say that there was no system. So it was that there is no community palliative care. And I was fortunate enough to see the different models internationally and know what will fit culturally for my community. And I think COVID itself has really sold that to us, that, you know, the community palliative model is where we're going to continue to go. We are, I mean, I could speak for Trinidad, we're aging population. So we have no choice but to put these things in place, because what's coming is, where am I going to go? When it's my turn to go, and when it's my turn to access healthcare, what's going to be there for me? And if I truly want to live in this country and want my family supported, I have to make sure I build a model for them. there was, when I was a fellow, I flew back to Trinidad for 2 weeks for a wedding, actually. And when I arrived home, it just coincided with my grandfather's death. And I said, oh, you know, I'm a palliative doc. I got this. And it was such an experience to me because there I trained with, you know, call the respiratory therapist. And I realized here I am wanting to come back to Trinidad to build a community palliative medicine program. But you need the support of a team. I went to 4 pharmacies to get 1 medication. I couldn't find oxygen. It was like a very, very fragmented system. And I think that was really my moment, that it took my vision and my passion and okay, so I know my why. We all know our whys, but the question is how. So that's where they started working on that how.
Yeah, great. And BJ, how about you? You know, like that translation, you talked about the big medical background and now this movement further and further out. What has pushed you there, and what are the key things that you feel like are making it successful for you? Yeah.
Well, one thing is it's been really, you know, letting go of the medical piece was both strategic because it allowed Sonia and me to hang our shingle quickly and to, without a lot of upstart financing and EMRs and blah, 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 to actually just get in the way of people who need help, who are floundering, who don't even know what they need. And we get calls like that. People don't, I'm not sure why I'm here, but I know I need something, essentially. But it's also true, like, so it was an expedient way to get started. It was also a way for us to really focus on all the socioeconomic and spiritual and structural issues that fall out of the typical encounter. It also has had this very welcome effect of depathologizing the subject matter. So as a disabled person, I'm very used to this. I get pathologized, that there's something wrong with me is the language. And, you know, I don't think of myself anymore as something wrong with me. And most people who live with chronic illness or disability eventually get there themselves. They're not broken. They may be missing some body parts or something, but not broken. And that's something, being pathologized, the experience of receiving that kind of energy is really very problematic. And so we can talk more about that if it's useful, but just to back to the question, what we're experiencing at Mettle Health, which has been so exciting, is now people are reaching out to us who don't even, illness isn't even the mix. Excuse me, they're having what we might call an existential crisis. You know, folks have reached out to us because their marriage fell apart or because they want to change their job. Clinicians reach out to us both to learn some primary palliative care stuff, but also to be supported, to be heard. And sometimes it feels like all we're really doing is set up, it's almost like a confession booth. It's like a place you come to just be honest. And that's a lot of the feedback we get from our clients is the endpoints are things like confidence, you know, reassurance, you know, you try finding that stuff in a medical research that those are beautiful outcomes, but they're not typically considered outcomes. But that's where we land with folks. And they're not, and we're de-shaming things. We're helping them be, you know, embrace their reality. That it feels gorgeous to me. It feels proportionate. And it feels like our job is really not to teach teach people things, but more to evince this strength in them, the confidence that's in them. That's why our word mettle really works for us. So anyway, sorry, more long-windedness, but this idea of depathologizing the subject matter has all sorts of really salutary effects, both for us as providers and very clearly for our clients. And it allows us as providers to see ourselves in the clients and vice versa. And there's this very sort of person-to-person thing that's actually just magically, organically happening. And it's beautiful.
Yeah, it is beautiful. And it's the core of who we are as humans, you know, that connectedness. And you touched on things that as nurses, you know, we've measured for years because we do have process measures, checkbox, but making sure people feel more confident, that they feel like they know what to do in the event things change. You know, those are really important measures that are now becoming a core of a lot of business models too, because of consumer engagement. And if you don't have consumer engagement, especially this, which is another huge opportunity for those on this call that are interested in palliative care. Part of what we do, we have a very poor batting average, even when we do create things that are great for people and getting them to engage with us, and not those on this call specifically, but other programs. So thank you for sharing that with us. And, you know, Michael, I've known you for some time, and we've talked, you know, about this journey as we both have ventured outside of the traditional healthcare systems. And I'm just curious, that same question, as we're talking to other medically minded entrepreneurs here on this call, and those that might be thinking about it, you know, not necessarily what that moment was, but where you feel like you're going, and kind of how we've already know what shaped you, but now, you know, how you plan to use that moving forward, and what Resolution Care is doing too. Yeah.
We'll answer that question, but first I just have to give an endorsement to Mettle Health, because I didn't realize it, but as described, that's what BJ did for me in 2014. He listened with an understanding that what was possible would reveal itself if I could re-embody myself, if I could get out of my whining and complaining. And so he did it in an Irish pub. Now telemedicine works just as well, but it's the same thing, and it matters whatever you're facing, whether it's a serious illness or a moment of professional crisis. So just like that really struck me when you said that, BJ.
Right on. Thank you, buddy.
Yeah. And then this whole idea of me as an entrepreneur, I've been racing to get out of control of my business since I started it. Because I know where I live. My first language is the language of the bedside. I barely speak fundamental language from the spreadsheet downward, but I recognize that bringing those two things together in some fashion and being willing to stand in the heat of the tension between those two things was something that I could do. Like, I know that those people who write big checks and finance doing stuff would love to be doing something good as well as achieving the numbers that they want. And I know that the people down at the bedside or in the beds, for God's sakes, all they want access to the simple offerings and value proposition of this work. And getting those two things means that I have to be bilingual. One, I speak like in my sleep, it's the air that I breathe. And the other one, I'm trying to like manage that tension between it. There's the other thing I wanted to say before I go into where do I think this could go, who knows, you know, but this piece about how we objectify, identify patients as patients, where they're missing parts or pieces or disabilities or whatever it is. We might also be blind to the fact that we grasp and attach to the identities that our privilege has allowed us to learn, to earn, right? Doctors think of themselves as doctors, and nurses think of themselves as nurses, and we really find solace in having checked the box and earned some credential, as if that in any way is an admission ticket to understand another human being. It is an admission ticket to enter the space, but in terms of being effective, it has very little to do with what's effective. What will deliver the results is our balancing out what we know and our knowledge and our, you know, expertise and mastery as a professional with a willingness to be self-aware and to be the human being that is so naturally capable of resonating with somebody who at that particular moment in their life, they're the one that's suffering. At another moment, it'll be you. But it's in that kind of leveled power dynamic where healing can happen. So I wanted to highlight that. And then where we're going, who knows? You talk to our investors, we're going to the moon. We're going to be big, 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 big. For me, from the bedside upward, I just want everybody who's super duper sick and suffering and engaged in the healthcare system in some fashion to have access to kindness and compassion and whatever expertise that comes with our professional roles, symptom control, the ability to walk into hard situations and facilitate communication and alignment in family systems. Like, it's so beautiful when that works. It's not rocket science, and it's not because I'm a doctor that I'm doing it. It's because I've been paying attention to 10,000 people and their families as they've been trying to teach me while I've been thick in the head. Like, here's how you help me. I was like, well, here's what I do to help people. You know, it's like the back and forth thing until you get smart enough to let go of your training and show up to the current moment. So the only thing I know for sure about the future is that it actually hasn't happened yet. But if you talk to the board and the investors in the organization, we're going to grow and provide this kind of service everywhere because it's needed everywhere.
Yeah. And you've brought up some words just now that I think, you know, in the world of entrepreneurialism that we have to be, you know, mindful of, and those are the investors. And I, having been raised in a not-for-profit hospice, you know, came about this with a lens that was very differently than how I feel today. And when you build something really cool and that's solving problems, and you can demonstrate that it's solving problems like all of you have, people start to line up and see the value in that. But you don't want to take money from just anyone. And there was a question that came through about aligning with our own mission and values as you're growing a company and you're thinking about scale and, you know, manifesting what we know inside. And I think that it's very important, this topic of knowing who you're working with, but aligning with people who have the same strategic mission, vision for what you are doing, and understand that the time that it's going to take to do that in an investment world, you know, and the turnaround time on that, to maintain the quality and that struggle between the mission and margin is upfront discussion. And those operating agreements, and I can't say this enough, are very, very important. And the governance structures that you create are very important to make sure that you're aligned with something you feel comfortable with longitudinally and or won't be sold up the river and changed. And so I think that I just want to highlight the importance of that I have learned as an entrepreneur. And you know, there's a lot of really great questions coming through here. I do want to highlight everything related to palliative care. There was a wonderful consensus project that was done amongst the largest palliative care organizations in our country that really touches on the principles of palliative care. The Center to Advance Palliative Care has also done really good work on how to, you know, sell what we do and create the value proposition in that. The National Hospice and Palliative Care Organization also has complementary work and just created a piece called The Future of Serious Illness Care in America. It was just published and it's very good. It's on their website, free to the public, and it kind of highlights some of the opportunities, both from a value-based perspective, social perspective, for various organizations. We can't go to people frustrated anymore. And I think that is something I want to talk about. And Chelsea, you mentioned that. I know we need to go to questions, but I want to talk about this. Chelsea and I talked about this. You can't go to the haters or the people who think you can't and say, well, you're not doing it right. Why won't you? I think a key thing before you create any business plan or before you create a solution, and Michael just touched on this, is that translation. And how do we know how to translate? Well, in palliative care, we become culturally competent, right? And how do we become culturally competent? We listen, we're curious, and we ask questions. We afford that of our patients. Why do we not afford that of the banks that fund us? Why do we not afford that of the chief financial officer at the health system that feeds us patients? Why do we not afford that of the local grocery store that might, I mean, what I'm getting at is the curiosity that lives within us. If we can translate what we believe people perceive as hatred of the services we provide and or judgment of the services we provide can be translated into really strong intention when you understand what fuels them and you really hear that from them and want to solve their problems. So before you create any business case, this is the key fundamental that you do for all stakeholders who would touch any part of your product, be it human capital, a tech service, telemedicine, a virtual platform, or human services like Chelsea has. So Chelsea, how are you facing that and being curious in your own environment today?
I just want, before I answer that question, I just want to touch on what BJ and Michael both said. You know, I hear a lot of support coming for other physicians. And I think one strong point here is that support is so necessary. And I congratulate BJ for what he's doing. And that's something that we do as well, because we all know that there's not enough palliative medicine specialists to really cover and give the need that we require. So for us being able to have the ability to support those general practitioners and those people out in the field is huge. And I could see that Michael was very grateful for BJ's support. So great for that, BJ, and I wish you all the best in that. And then to answer your question, Katy, just repeat that question for me.
Yeah, just you were just touching on it earlier, yesterday with me, how you have dealt with the understanding, you know the culture, but how you're dealing with that, you know, in order to create a business plan that works and a program that works, how you have to lean into and understand the needs of your stakeholders. Yeah,
exactly. And that has had exponential growth, because I think, as Michael said, we're doctors, right? We're trained as doctors, we're trained as nurses. Our passion is at the bedside or in the bed, right? But yes. Then when we actually have to run a company, it's great for us to idolize, oh, this palliative medicine company. But how do we actually create it and actually allow it to be sustainable? And that's where I'm at right now. In Trinidad, we're a little bit different. We are public and private. And if you're private, it's fee for service. Most people don't have insurance. And really and truly, what I'm doing at this point is maximize. I appeal to the people that I can, and I try to maximize myself to the others. However, I'm quickly learning that, you know, we only have limited resources. And I hope that the government of Trinidad and Tobago will one day see the value of palliative medicine, and us as a team are so willing to support them. So I'm hopeful that that will come about soon, and we could continue to create really equitable access to palliative medicine in Trinidad and Tobago.
Beautiful. We can't wait to hear how it goes. We cannot wait. So we have 5 minutes. Are there any major questions that we have missed here in this chat that our panelists would really like to address, and or, you know, kind of give us your 1 minute take home? I would say I open it up to both a question and a take home to our panelists as we close out.
Well, maybe while we're waiting, I'll just jump in, Katy. You know, I saw a question come up around how do we depathologize? How do we? And I think you guys answered it one way and another, which is just put down your need to be the expert in the room and listen, be curious. That confers a respect, a dignity. That's what depathologizes. That normalizes the experience. So that's the answer to one of the questions that came through. And I would say, if I only had one little piece of it's like, again, kind of conceptual, but try not to separate yourself from your patient. Michael got at this earlier. We are variations on themes as humans. And that is an allied place. That's the opposite of a divide. And this subject matter has this potential to unite us and link us. So dare, as a provider, as an entrepreneur, dare to see yourselves in your patient, dare to be the sufferer, own your own experience that way and help others own theirs.
And if I could circle back, Katy, I so appreciate what you said about the boardroom and the investors. They're a stakeholder group of great importance. And it turns out they're people too.
Yeah.
I had two strategies. One was to quietly, slowly, and surely kind of become at least fundamentally fluent in the language that their love language of numbers and results and all the rest of it. That the other was to race to building a team of people who speak that language like it's the air that they breathe, who can resonate and want to learn the language that emerges from the carer, from the bedside. And so both of those two strategies, I've learned a little bit about how to understand what scratches their itch. And I've attracted a circle of people around me that are so much smarter in so many dimensions as fast as I possibly could than I am, to broaden the sort of the blend of leadership in the organization. That was, and it was a race to the finish, or a race to the current state, to do that fast enough, because I couldn't learn fast enough. And I didn't have the resources to gather people fast enough, but we apparently are making it that with those two coherent lines of reasoning.
Yeah.
And I would also second what Katy said. First of all, I don't think if you're trying to think about starting off in that entrepreneurial path, I would advise you don't need to reinvent the wheel. And I could advocate for CAPC. I would say a large part of where I am right now is because of CAPC. And there is a lot of resources available. This is not a paid advertisement, but there is a lot of resources available on CAPC on all different structures that I found really useful and I continue to use all the time. I mean, even how to advertise. I saw somebody asking a question, how do you change, the palliative brand? That is so helpful in terms of terminologies to use. They have all those resources available.
Yes. And I wrote down a couple of quotes as I was talking to you guys that resonated to me, and thank you for sharing today. You guys are amazing. I wish we were in person, because I'd love to give you a hug and say thank you. But when you are thinking, those on this call, because there's about 2/3 that are thinking, or some that aren't interested, but your new life, even if you're staying and continuing to follow a path that's already there for you, your new life or your new thought patterns may cost you your comfort zone. Be uncomfortable, because that's where the change happens. And nothing is permanent, nothing is stuck. You have choices about this, and there's going to be haters, there will be doubters, but then there's going to be you who's going to prove them all wrong. And I mean it. You can do it, and you will do it, and we have to do it for the sake of the serious illness needs in America. So thank you, Hospi. Thank you, panel. I am honored to be here with you.
Thank you all.
Thank you, Chelsea. Thank you, Michael.
Thank you, my friends.
Bye-bye.